there are many patients we would have intubated in the old days if it's not for negative pressure ventilation.
Welcome to PedsCrit. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
Today, we're excited to be discussing negative pressure ventilation with Dr. Omar Alibrahim. Will you please introduce yourself and tell us where you practice and some of your professional academic interests related to today's topic?
Thank you for having me to the podcast, Alice and Zach. It's always a pleasure and an honor to be with you. My name is Omar Alibrahim. I'm a pediatric intensivist. I serve currently as a PICU Medical Director at Duke Children's Hospital and Pediatric Critical Care Program Fellowship Director. I've been at Duke now for almost 4 years. I spent most of my career at the University of Buffalo, where I served as the division chief of the Pediatric Critical Care Division and the PICU Medical Director, and other roles, including the Fellowship Director, ECMO Director, and the apheresis Director through my tenure over there. My clinical interest falls probably mainly into respiratory care in critically ill children, mainly in mechanical ventilation, especially non-invasive respiratory support, and particularly in negative pressure ventilation, in addition to extracorporeal therapies.
Oh, well, Omar, you've had a robust career in a lot of respiratory care research and a consistent thread of leadership and leading these programs. As you think back on your career, what were your key motivators and what advice would you have for early career faculty sort of approaching these systems for the first time?
No, thank you for this question. And to be honest with you, I always think about what led me to this journey. And I think the key motivator to me was always patient care. And we all, come to this field because we love to take care of patients. We love to take care of critically ill patients just to try to provide that support, not to the patient per se, but also to the families during very difficult times. And we find it's a privilege for us to do that. So that always motivates me to be an excellent intensivist, as excellent as I can be, for selfless reasons, but also for selfish reasons, right? And I think they intersect a lot throughout that journey because we want to do really what's best for patients and try to be innovative and creative to do so. And in order for us to be able to do that, we have to be really outstanding intensivists. And this is why always the advice I give to the fellows, like for you to be an excellent intensivist, you have really to read and know well. And your reading and your self-studying, that's 50% of that excellent intensivist. And the other 50% will be at the bedside. You can spend day and night at the bedside and you're not going to be on that 50%. And you can be buried in books and articles and fantastic podcasts like yours, and you will get to that 50%. So you have to be both. So I find myself motivated by that core value, which is excellent patient care. And that's what led me to negative pressure ventilation, one of the things that I'm very passionate about.
Yeah, I really appreciate the practical bedside approach and how important it is for our families and our patients. And we are so excited to jump into negative pressure ventilation as a means of logistics for the last question. Before we get to that, any conflicts of interest to disclose?
None, unfortunately.
Oh, wonderful. Let's get right to it. So negative pressure ventilation. As a pediatric intensivist who doesn't have any clinical exposure to this, I have somewhat of an idea what this might be, but please define it for us. What is negative pressure ventilation?
Absolutely. So negative pressure ventilation is a form of non-invasive respiratory support that works by exposing the anterior chest wall to subatmospheric or negative pressures that leads to pulling of the chest wall outwards, recruitment of the lungs and the alveoli. It really works by using a plastic shell or a cuirass that we apply to the anterior chest wall that really sits below the sternal notch, down to the mid-abdomen around the umbilicus and across the mid-axillary lines from the sides. You use this using a foam, a spongy foam that helps to provide the seal, but also provide comfort to the patient.
Oh, so correct me if I'm wrong, but it seems like it's kind of sucking the chest wall out.
Exactly. That's very true. Yeah. And it depends on of course, the modality that you use, but basically just by creating that negative pressure, it just pulls the chest wall outwards, and that leads to the recruitment of the alveoli and the lungs, and as a result, decrease the work of breathing and improve alveoli in terms of gas exchange, so improve oxygenation and ventilation.
So We were talking before this about how it seems really interesting and exciting for infants and small children in respiratory distress and also for cardiac patients. Can you tell us a little bit about the physiologic rationale for each of these groups?
Yeah, absolutely. And I think, just maybe to go a step back, I think to remind ourselves how we normally breathe. That's one of the core things that we have to learn or to remind ourselves about it before we dig deep into negative pressure ventilation. So the way we breathe, basically the contraction of the diaphragm, what starts the whole thing, in addition to the contraction of the inspiratory intercostal muscles, which leads to the downward displacement of the diaphragm and outward movement of the chest wall. This exposes the lung to a larger overall volume. And if you go by Boyle's law, where the pressure is inversely related to the volume, that necessitate a fall intrathoracic pressure, which lead to creating of a gradient that forces the air to move inwards because we have negative pressure inside the chest compared to the atmospheric pressure of 0. The reverse happens during expiration, where the chest recoils takes place, and then the negative pressure inside the alveoli will be reversed to positive pressure, which exceeds the atmospheric pressure of 0, and that will forces the air outside. So when you apply negative pressure ventilation to the chest wall through the cuirass, we're creating negative pressure in that space, and that will result in negative intra-alveolar pressure as well, which create that gradient of flow that forces the air to go inside. During expiration, the opposite happens, where the pressure is positive, and that will create positive intra-alveolar pressure, which forces the air to the outside. The difference and the big advantage when you use control mode, for example, that expiratory phase is an active phase, is not a passive phase, does not depend on the chest wall recoil, so which makes it really integral and important in somebody with sick lungs, especially with kids who have very compliant chest. That becomes really significant, and that exaggerates usually their work of breathing just because they have very compliant chest. So negative pressure ventilation, in addition to be mimicking the spontaneous way of breathing, in the exhalation, it's an active phase, so it helps the patient exhales without depending on the other factors that we cannot control in a sick lung.
I really appreciate that overview of how negative pressure ventilation affects respiratory physiology. As an intensivist, we always think about how the heart and lungs work together. And, with CPAP and BiPAP, we always talk about how that affects both the right heart and left heart. I wonder if negative pressure ventilation affects those differently. Will you overview how negative pressure ventilation contributes to cardiopulmonary interactions?
Yeah, no, absolutely. And I think that kind of explanation takes me to this question exactly. If we think about cardiac physiology, especially patients with Fontan, patients with Glenn physiology, where the pulmonary flow is a very passive pulmonary flow. And if we step back a little bit, when we talk about RV preload, which is the venous return to the right atrium, that's really determined by Ohm's law, which is the driving pressure over the resistance of the venous system. And the driving pressure, as we know, is the difference between the pressure in the great veins compared to the pressure in the right atrium. The bigger the difference, the bigger the driving pressure, which is the better the venous return. Applying positive pressure makes the driving pressure smaller, and that will affect venous return. So in patients with Fontan, for example, when their pulmonary flow is passive and the blood basically goes from the inferior vena cava, superior vena cava to their lungs directly, any direct effect on that venous return would have a direct effect on the cardiac output. So applying a positive pressure would increase the right atrial pressure, would decrease the driving pressure, and that will lead to direct decrease in the cardiac output. So Fontan patients post-op, if they need any ventilatory support, negative pressure ventilation will be very favorable, because by creating negative intrathoracic pressure, that will lead to decrease right atrial pressure, make it in the minus, and that will increase the driving pressure, and that will improve actually their cardiac output. And that has been shown, by Dr. Shikhar back in the 90s in her two famous papers, 1995 and 96. And there was a publication also in 1999 that kind of talked about these, and it showed very eloquently how the cardiac output significantly improved within 15 and 45 minutes of applying negative pressure ventilation to patient after right-sided heart surgery, and showed that also in Fontan patients. So definitely the evidence been out there, which matches our pathophysiology knowledge of that lesion and what negative pressure ventilation can offer.
So it's so important. So I wanted to summarize. So our patient with restrictive right ventricular physiology or pulmonary blood flow that is passive, negative pressure ventilation theoretically should help that patient. It should help their cardiac output, should help with venous return. Is that correct?
It is correct, especially for Fontan patients with single ventricular physiology, but patients with biventricular anatomy, like patients after tetralogy fellow repair, in addition to the effect on the RV preload, there is also potential beneficial effect on the RV afterload, which is pulmonary vascular resistance. So applying negative pressure ventilation and recruiting the lungs appropriately, that will give you the best FRC, which will give you the lowest PVR on that famous curve that we all very aware of. So in addition to improving the RV preload, we optimize the RV afterload. So it makes it much easier for the right ventricle to contract and move blood forward, which also would optimize the LV preload, which usually depends mainly on the RV conditioning, the preload and the afterload. And if the LV is healthy, then if you think about it as plumbing, basically, all the blood will move very easily throughout, and that will improve the cardiac output of the patient. We have to be very mindful. Patient with LV dysfunction, negative pressure ventilation might not be the best because that will increase the stress against the wall of the left ventricle and will increase afterload. So we always have to be very mindful of that piece and see where your patient problems or pathology kind of falls into and what kind of ventilation strategy would be more applicable to this kind of patient.
Oh, absolutely. Now, I have to ask, and understanding that anytime you add something to a cardiac program, it's close conversation with the surgeons. But what can you use it immediately post-op if the kid has a sternotomy?
You can, and it has been used very successfully. One of the soft contraindications is, in general, I think, having thoracic surgery. But for these particular patients, like especially Fontan patients, even if they have chest tubes, you still can use it on a fresh post-op, as long as you're mindful for the foam or the kind of the edge of the cuirass not to fall on the entry point of that chest tube. But you can use it successfully for these patients.
Oh, thank you.
So it seems like we have a physiologic rationale here where negative pressure ventilation can help with alveolar recruitment. Also has some ways it can help with improving venous return to the right heart, but we need to be mindful that we're not using it in patients with left ventricular dysfunction. You've already introduced some of the literature in this area. Do you mind also just surveying what all we know, what evidence do we have that supports the use of negative pressure ventilation in critically ill children?
This is always the question I think that I get from my colleagues because, we always want to practice evidence-based medicine, even though I think we realize very quickly that most of the therapies that we do is not really evidence-based. That being said, I don't think we have tons of evidence, and I think negative pressure ventilation has a unique position, probably not in a favorable way. That's been the longest therapy that's been known to us in a critical care field, if you will, and has disproportionately the lowest amount of evidence that's out there. Because if you look back, negative pressure ventilation has been available since the 1930s, at least in the market. And actually, when I did some research for a few talks, it started back in the 1600s and 1700s when people did think about it and came up with some of the models that kind of led to creation of the iron lung later on. But yeah, unfortunately, we don't have tons of evidence. And I think the best probably evidence, and I'm a bit biased, is our study that we published in 2017 with that large case series, 233 patients. And that just reflected the first few years of our experience when I was back in previous institution in Buffalo. And I would say now probably we have exceeded probably 700 patients easily, which I've been in discussion with my colleagues to have a follow-up. But other than this, I don't think we have any better evidence. And I think just to be mindful of other treatments. If you look about other forms of non-invasive respiratory support like BiPAP or CPAP, we don't really have the greatest evidence as well, but we're very comfortable using it in every ICU in the country probably. And I think I can come up probably with two good studies that looked at that use. Yanis and Peters in 2008, 2018. Other than these two studies, everything is very case series kind of studies. So unfortunately, we don't have a lot of evidence to how we practice, and that's been very eloquently written, I think, in that paper by Jerry Zimmerman and some of the pioneers 2016 related to research as a standard of care in the PICU, which kind of speaks to the state that we have and a call, I think, to use the data-rich environment that we live in to include every patient that we have in some kind of research project like our colleagues in hematology and oncology do. That's a different topic, but I just want to kind of state that out loud.
Oh, yeah. No, it's something we say on rounds, but should take to heart that if we're questioning the evidence for the standard of care, especially when we're maybe changing it
I mean, I think many of the practice and the decision making that we do at the clinical basis, I mean, in addition to the evidence that we use, I think we depends a lot on the pathophysiological facts that we have learned, in addition to the body of experience and knowledge that we gained over the years. So it's not, I don't think we should be handicapped, I think, by lack of evidence. I think we should be encouraged by how well we do things, because, I mean, the mortality in pediatric critical care is very low. So must be one or two things that we do very well. But that should not stop us from being more evidence-based and doing more trials and creating more evidence to our practice. Again, that's a different
talk.
Absolutely.
Absolutely. So this is really a robust clinical program at the Oshai Children's Hospital at the University of Buffalo. And when we think back, we interviewed Furman. We know Buffalo has this really rich history of trying unique respiratory things, right? They did liquid ventilation. They used perflubron. Can you talk to us about how you were in Buffalo, maybe had the idea for the clinical program and how you built it up?
Yeah, absolutely. And I think when it started, actually, I was just lucky enough to be there on service. One of my colleagues from MedPeds been in contact with the FDA to have an approval to bring a machine from Britain to serve a patient with cystic fibrosis. And at that time, we used to take care of all the cystic fibrosis patients in the PICU, young or old.
Oh, yeah.
So I had just the honor, I think, to be there in the PICU when this patient came in, and we were kind of navigating and trying to learn this machine with our respiratory colleagues. I was very fortunate to have an amazing respiratory manager at the time. And he and I, we always kind of work very well together. If I see something that's interesting or exciting, I will say, Mark, like, this is a new device that maybe we should look at. And he will do the same. So our interests kind of combined when we saw this negative pressure ventilation device, which I never heard of. So I went to Dr. Google to find out what's happening. And I found maybe 2-3 case series from Britain used, and I saw a couple of videos. And it seems, I mean, the device makes a lot of sense to me. And the most important thing, it has minimal harm, if anything. And I think I always remind myself, do no harm is the most important thing. So it seems like it's a minimal harm. It can be useful. It makes a lot of physiological sense. So why not bring it on and learn more about it? So that's really what triggered the whole start of the program. So we contacted the company, and they came in and they did some in-servicing for us. And it seems the respiratory team was on board. Some of my colleagues were kind of excited to learn more about it. And we start kind of applying as a tool in our arsenal for patients who would need support. And initially, we targeting patients with neuromuscular disease because we thought this patient might need an extra support after they get extubated or when they become acutely ill with critical illness. And we ended up using actually more for patients with acute respiratory failure. And the biggest patient population from our study, which continued to be true, is patient with bronchiolitis with acute respiratory failure as a way of escalation from high-flow nasal cannula.
Oh, nice.
So tell me this, why did you choose bronchiolitis, you think? Like, looking back, why did y'all use that patient population to test isn't the right word, but trial negative pressure ventilations? Is there any kind of physiologic rationale that you think those patients would benefit more from that therapy?
This is a great question, and I don't think I know the answer very well, but I can show you exactly what was my thought process. And I think these patients basically choose us maybe more than we choose them. So part of, I think, when we started using negative pressure ventilation, of course, as a new technology, a new device, it took some time for everybody to be comfortable with, to buy it into the device. And I think it took probably, I remember very well, it took probably a year to 15 months for everybody to be very comfortable with the device, which is very normal, very anticipated. And I talk about providers, fellows, attendings, nurses, and all respiratory therapists. And one of, I would say, the onboarding process during this year or 15 months was for us just to do a trial as a pilot trial, basically just to see if this works for a patient and if this is safe to start with. So we choose to do this on bronchiolitis patients as a unified age group with no comorbidities. And we felt this will be kind of a clean sample just to do a pilot study on 20 patients and apply it and see if it's just safe to use. That was basically our goal, just a very low bar of achievement. That led us to realize actually that works for these patients when they come in and they're on high-flow nasal cannula and they're not doing well and typically would use CPAP or BiPAP, and you know all the nightmare finding the appropriate interface for a 6-month-old. It doesn't happen in 80% of the time. So by us kind of onboarding and getting us to be more comfortable with the technology during that initial period and try to add a little bit more science and evidence to our practice, it seems patient with bronchiolitis seems to be benefiting from it. And we continue to have our focus on patients with neuromuscular disease, patients with these challenges. And we published actually our first experience during the ASA conference in a poster looking at 14 patients using negative pressure ventilation with underlying neuromuscular problems. But at the same time, we're getting more comfortable with the machine itself, and we get to know it more and more. And when you read about something compared to when you practice it and try to troubleshoot it at the bedside is very different experiences. So I think the combination of doing this pilot study on broncholytic patients, in addition to us using it more and more in the unit, and the fact that during the winter months and during the busy months, most of your population will be patient with bronchiolitis. By default, patient with bronchiolitis became the most common users, I would say, of this device as a result of all these things that I just mentioned.
When you have babies with respiratory failure, even when they're not sick, that closing capacity or that lung volume where they need that minimum to maintain recruitment is so close to FRC already. And then as soon as their lungs get sick, these babies are so prone to atelectasis and hypoxia that comes from that. It seems like negative pressure ventilation could be well suited to maintain lung recruitment. And then think about how agitated these babies get when you're trying to put a non-invasive interface on them, like BiPAP or CPAP. It does seem like that would be a low-hanging fruit, so to speak, a patient population that might benefit. Any other lessons learned from managing these patients with negative pressure ventilation? And then also, what did the parents think about this?
There's a lot of lessons learned. It was interesting at the very beginning. There's a patient, bronchiolitis patient, who's not doing well on high flow, and we're looking for BiPAP and CPAP. I introduced the idea of doing negative pressure ventilation. At the very beginning, it was myself and one of my colleagues who were the champions of it. So we would only apply it if we were around or on service. And then I'll go talk to respiratory, and I'll kind of come back to talk to the family. And the family had like a complete change of mind because the nurses would tell them, yeah, don't use this device. We haven't used it as much. Then I would say 6 months into it, it was quite the opposite. The nurses would ask me, I think we should use negative pressure ventilation for this device. And that reflected positively on the family. And later on, after a year or so, families would ask, can we use this negative pressure ventilation? And we had one patient who was a frequent flyer to the PICU patient with SMA type 2, who, of course, was BiPAP dependent, who would come very frequent to the unit with aspiration or respiratory infection. And mom heard about this, and mom was a huge advocate for her child. And one of her admission when she was, I think, 2 years of age, we used negative pressure ventilation as a way to support her in addition to BiPAP before considering intubation. And it really helped her a lot in terms of support, in terms of comfort as well. After she left the ICU, we worked with her and the insurance company. She was our first patient to go home on negative pressure ventilation. So the parents, had a significantly favorable view to this when they started experiencing it. Other patients with no comorbidities who had never been in the ICU, who heard from other families or from the nurses, and also parents with got a lot of experience in the ICU and big advocate for their patients who had also very favorable. So in general, I think from a family perspective, there was a very favorable view of negative pressure ventilation, just because you don't put anything on their loved one's face and cause that agitation, pressure injuries, and aspiration risk, and all these problems. I think in terms of lesson learned, it was from a program development point of view. And I think for me personally as an intensivist, I was extremely passionate about this, and I wanted to push this very quickly. So I learned to hold the brakes a little bit and just get people to learn it more and more. I think it was a good opportunity for me to learn how to be patient with these innovations and with program building and introducing new ideas, and to probably better communicate at times. So it was very helpful early in my career to learn these skills. For us intensivists who are very opinionated, we feel very strongly and passionate about a lot of things, and we can be pushy sometimes, which is a good trait to have. But sometimes you just have to be a little bit patient and use this opportunity to provide more teaching and clarifications and get more buy-in before you implement something. And I think it took its time, which is appropriate. But I think that was, to me personally, the biggest lesson learned. And of course, there's a lot of little lessons that we learned through the way in terms of how to prevent pressure injuries, for example. We kind of put our protocol together to address some of these things, which I know we're going to talk about. So I don't want to be ahead of myself.
Oh, yeah. It sounds like you made a clinical change and then had the patients to let it almost spread itself, right? You got a couple nurses that like it. You got a couple respiratory therapists that ask about it, and then family members in a close city. And so people kind of know. Were you, and it sounds like you weren't division chief when you were doing this. So you had maybe maybe leadership that was willing to invest a little bit and take a chance, and then things grew from there?
Yes, this was a few years before I became division chief. So that was in 2010, maybe. So I was 4 years after fellowship. At that time, I was leading the ECMO program, and I just founded also the apheresis program. So I definitely had the ears of Dr. Furman, who was at that time in Buffalo as a division chief. I think if anybody had met Brad, I mean, he's one of the smartest people I have ever known in my life. And he's the one, if you bring him an idea that has some rationale behind it, he'll be very supportive, but he'll be watching very, very closely. So I have to be on my toes to make sure things fall into place very well. So definitely I had his support, and I had the support of my colleagues as well. And I mean, definitely partnering with respiratory therapists and respiratory leadership was a significant key to make this useful. Without having a physician champion, without having a respiratory leader champion, this will not have gone anywhere. And I think that's true for many things that we do in intensive care.
It's clear to see that you had buy-in from the top, your division chief, and then you had the core group of intensivists, and then you had buy-in from the bedside staff, nurses, respiratory therapists, and even parents, which we don't talk about near as much as we probably should in implementing change. And I'm even seeing opportunities from Child Life to get in here and decorate some of these cuirasses and seeing some Ninja Turtles and stuff like that.
That could be cute. Yeah. Yes. Yeah. Oh my gosh, that would be awesome. Wait, that's really cute.
But I'm going to steal that idea.
Yes.
No, but also you had this PICU that had been sort of trying new things for a long time. And I imagine a really engaged and supportive respiratory care division, right? Like the respiratory therapists were in Buffalo Sound.
That was the key. Yeah, for sure.
One quick follow-up question. I imagine a key metric that you looked at in managing these bronchiolitis patients with negative pressure ventilation was intubation rates. Do you have any insight into how often they failed compared to patients that were receiving positive pressure ventilation?
It was interesting enough to find out that it's very, very hard metric to find, even though the data is available. But anecdotally, I think we all felt that there were many patients we would have intubated in the old days if it's not for negative pressure ventilation. When we looked at the data, actually, ourselves from that paper, we compared the intubation rate in these 3 years compared to the intubation rate of the prior 3 years. And we found a significant decrease of intubation by like 23%, but it did not meet the statistical significance of the p-value. But again, if you ask anybody who practice in Buffalo, they will tell you for sure that our intubation rate has decreased. That being said, I think the care also has changed in critical care over this past 15 years. We have been using more and more of non-invasive respiratory support like BiPAP and CPAP compared to when I was a fellow, for example, which was a while ago. So I don't know if you can contribute this to only negative pressure ventilation, just to be very truthful, but also to the way that we have been practicing medicine in pediatric critical care and respiratory failure in ICUs in general. But I personally believe strongly that negative pressure ventilation use in my previous institution in University of Buffalo had led to decrease of intubation rate. And that's based on my anecdotal experience. And that also based on just talking to my colleagues and the respiratory therapists over there as well.
In the recent years, at least to me, there's been a more of a focus on self-inflicted lung injury and, watching, the driving pressures we're giving our patients and even thinking about, the patient's own respiratory effort, how that may or may not contribute to the driving pressure that the lungs see. We'll talk more about numbers later in the conversation, but do you feel that this deeply negative pressure that you might use in negative pressure ventilation, do you see it as perhaps being more lung protective as compared to positive pressure ventilation? Or is that just a question that's hard to, or nearly impossible to answer?
This is a great question. I think this is one of the things that I really would love to answer before I retire. The emphasis, I think, on patient self-inflicted lung injury or PCLE is becoming more and more of interest, I think, since the COVID times in adult literature. And I think it was like an awakening call for us to look into it more. And you'll see probably a few publications speak about the strain and the stress of the lungs and the stress expressed by the transpulmonary pressure and the strain expressed by the tidal volume and its relation to the FRC. And we haven't really studied that, I think, in negative pressure ventilation. And we haven't studied that in pediatrics in general. I think other than Robbie Kamani's work and looking into that, we haven't really done this in any other form of mechanical ventilation. And I would love to study that. And actually, we had a study that was ready to go just before COVID when I was in Buffalo, and we kind of stopped it. And basically, our aim was to look for what kind of tidal volumes we create when we apply certain negative pressure using the control mode in negative pressure ventilation, and to look at esophageal pressures as a reflection of the intrapleural pressure. And it was just before COVID and we haven't done anything. Then I came to join Duke. But this is one of the studies actually that we're interested to look here, part of it using probably EIT technology, as well as in the future, I think using esophageal pressures to determine the intrapleural pressure, but also understanding pitfalls of esophageal probes and the calibration problems and all that, not inaccuracy, I would say, kind of lack of affirmation of how accurate that's going to be or dependability on it. That being said, I think how to translate this to clinically, because I think if I talk to the bedside nurse or to my respective therapist about transpulmonary pressure and lung stress and lung strain and how we're going to be protective, I'm going to lose everybody like in 5 seconds, right? Mm-hmm. But what that PCLE means to me at the bedside? It really means the work of breathing, right? Because if the patient is on some form of mechanical ventilation, invasive or non-invasive, and their work of breathing is still very significant, I can tell this patient falls into that PCLE category, and their transpulmonary pressures is very high, and their stress and their strain in their lungs is very elevated, which makes their lung injury risk to be very elevated. And this is what I use also in my monitoring of these patients when I put them either on BiPAP and CPAP or in negative pressure ventilation as a surrogate of PCLE. What's their work of breathing? If their work of breathing improves during negative pressure ventilation, that tells me that the transpulmonary pressure probably are improving and much less than before, and their lung stress and strain is much less than before applying negative pressure ventilation. So I can feel probably more comfortable that negative pressure ventilation is improving patient work of breathing and minimizing the risk of PCLE. If you look at it from a pure theoretical point of view, if I'm applying like a negative 20 of centimeters of water through the cuirass, which I assume some of this pressure will be transmitted to the alveoli and the intrapleural space, I'm creating more negative pressure in the intrapleural space, and that might reflect negatively on the transpulmonary pressure by increasing that transpulmonary pressure. But if this is the case, my patient work of breathing should have increased, and that's not the case. I don't want to give like a too lengthy, confusing answer to this, but in theory, it might not be protective just because you apply too much negative pressure. And I think this is the argument or the discussion I think that I have with some of my colleagues when they seem like interested in negative pressure ventilation, like how come we apply so much negative pressure to the intrapleural space and anticipate that's going to be more protective because that will increase the transpulmonary pressure. And my argument, I would say, yes, in theory, that's true. I don't know how much of that negative pressure will be related to the intrapleural space and reflective on the transpulmonary pressure. But if my patient work of breathing is improving, I can be very comfortable that I'm not hurting this patient. Actually, that will be a reflection of the patient improvement of these dynamics, and that the transpulmonary pressure, actually, it's improving. So in a way, I'm not providing any harm. Actually, I'm helping my patient. So I don't know if that makes sense, but this is the way I would kind of think about it.
Yeah, I think so. Wonderful.
So Dr. Alibrahim, thank you so much for walking us through really how you built this program. It's incredibly unique. Do you have anything else to add before we move to sort of the nitty-gritty of how you use the cuirass?
I think in terms of program development, I think it's important also to be open-minded and to be okay to be vulnerable at times and not to take any defeat personally. Mm-hmm. And again, I think it's important to get your team to buy into the idea and to communicate frequently and to repeat the message and to provide more clarity either at the bedside or to the families or to your colleagues. And as long as the focus is the patient and patient care and advancement in care of the patient, you'll be always following the right direction. Make sure you put your ego at the door before you walk into the unit and focus on your patient and advancement of the program and advancement of the care that you provide in the ICU. That should be your goal. And I think as long as you have these in front of you as the main goals of doing what you're doing, things usually will fall into place very nicely.
Oh, well, thank you so much.
Thank you.
And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.